Oops. Hold on. Accidentally started transcription there. Okay. All right.
All right. Well, welcome everybody. Thank you for coming today to our, what is this, our second or third informational session with BCPH. Today, we're going to have the very exciting topic of transmission-based precautions. And really, the purpose of this is not to, bring up just bring up the horrible times, with COVID and all the PPE that was, required with the guidance and, just it was a lot to go through. But that, can cause a sense of burnout in staff and residents and visitors. So really, this is just a refresher course and then some ways that we thought of that you could use with staff or with residents or with visitors to remind them of the importance of it and some fun ways to just kind of bring it back into the community as we're transitioning away from the pandemic and kind of into just making it more endemic and seasonal. So that is the purpose of this. Rebecca, next slide, please. Oh, I'm sorry. I'm Katie Paniga also, and I'm going to be walking us through the fun today. So our agenda, I know this looks really long, but all the slides are very brief with each of these. So we're going to walk through respiratory hygiene and cough etiquette, some hand hygiene, breakdown of precautions, the different type of precautions that there are, briefly talk about the importance of PPE, walking through this sequence of donning and doffing. Resident placement, we'll just briefly talk about some of the resident placement issues that we've seen and some strategies for some of those issues. We'll provide some training and education resources. We'll briefly discuss common PPE mishaps. We will show you the Jeopardy game that we created. I don't know that we'll have time to play it, but we might be able to walk through a couple of them, but it's more of a resource that we wanted to share with you. We'll provide an update on human metapneumovirus and then walk through our current contact information with our team and then end it with a Q&A. Next slide, please. Okay, so first kind of walking through respiratory hygiene and cough etiquette. So in terms of, respiratory infections in healthcare settings, there's some infection control measures that should be implemented at the first point of contact with a potentially infected person. So these are some of the infection control practices that are one component of standard precautions that should go into place. And so the first would be posting visual alerts, and this can be in different languages too, as appropriate to your facility. So that might be English and Spanish, or some of the other, just as appropriate for your facility. But posting that signage and having it available in different languages is a great practice to have. And we recommend posting signage at the front door or the front of your facility for anyone who's walking through the lobby, whether that be, family and friends of residents or any sort of outpatient staff that come in, anything like that to inform, to better inform them of what's going on. And so that it can include stuff like covering your mouth and nose with a tissue when coughing, using the nearest waste receptacle to dispose of that tissue after use, and then performing hand hygiene. So also maybe providing some sort of waste receptacle and then having something like hand sanitizer available in a lobby or upon entrance and after someone might see this sign is another great way to kind of reduce exposures and practice that proper hygiene and cough etiquette as someone's walking into your building. Next slide, please. Okay, so moving kind of into hand hygiene, again, nothing new here, but just wanted to briefly go over the importance of hand hygiene and the different types of hand hygiene. So, the most important part of proper hand hygiene is scrubbing for 20 seconds. That is the golden time that will help remove harmful germs and chemicals from hands. And that also is is inclusive of friction. So you'll want to make sure that there's friction between your hands, including, on the back of your hands, between your fingers, under your fingernails, stuff like that, that will physically destroy the germs and remove germs and chemicals from your skin. So in general, the CDC recommends the use of hand sanitizer as the primary method for hand hygiene in most healthcare situations. This is a great way, especially with how often staff are needing to perform that hand hygiene. But there are instances in which soap and using warm water and soap and using that friction is a more appropriate and should be used over hand sanitizer. And so that would be in different situations where there might be an outbreak of certain germs like norovirus or cryptosporidium, C. diff. Those instances, whether if you've got one resident or staff with experiencing those symptoms or, with a positive test or multiple, you would want to then switch to only using soap and water as the more effective use of hand hygiene, just because that is the type of proper hand hygiene that would kill those germs. So in that situation, you would no longer promote having hand sanitizer as an option when performing close patient care or anything like that. And this sign here on the right, the hand sanitizer use out and about, we do have this in a PDF form, and we'll include this in the follow-up email after this. So this is something you could post. It kind of walks through when you should use soap and water versus hand sanitizer. In general, it's more of a generalized poster, and just another great way to practice this. And then, in certain types of outbreaks, then you're able to implement that more proper form of hand hygiene. Next slide, please. Okay, so in terms of the different types of precautions, so we'll start with standard precautions, and we'll walk through a couple of these a little bit more in depth. But standard precautions are basically kind of those common sense practices that you would use for all patient care. And there's nothing really, it's more of your basic types of precautions. When you're moving into contact precautions, these would be something you would use when there's a known or suspected infection with an increased risk, and you would use contact precautions at that point. Droplet precautions are more for coughing, sneezing, talking anytime there's respiratory droplets that might be generated. Airborne precautions are for suspected or known or suspected to be infected with pathogens transmitted by the airborne route. So some examples would be someone with tuberculosis, measles, chickenpox. And then empiric precautions are when an organism is unknown, but there's concern for communicable disease transmission, oftentimes more with GI, so vomiting, diarrhea, rash, coughing, and you would use PPE as appropriate and kind of more on a case-by-case basis with those. So next we'll go and do a little more into standard precautions. Thanks, Rebecca. So again, here's another poster on the right. This is one that you could post around your community or in the staff break room. So we'll include these in both English and Spanish in our follow-up email for these next couple slides. So for standard precautions, again, I'm not going to talk through about this one, more in depth to an extent, but these are used for all patient care. So they're based on a risk assessment, and they make use of common sense practices and PPE use that protect healthcare providers from infection and prevention that spread from patient to patient. Let's move on to contact precautions. Okay, so contact precautions are, kind of the next step. So this would be something you could post this signage on the door of a resident who is experiencing an infection that would warrant contact precautions. And the type of illnesses that we're looking at that would require contact precautions would be things like C. diff, scabies, norovirus. Those would be the type of infections that you would want to warrant these contact precautions. And so that would be ensuring appropriate patient placement in a single room or space if available. We'll talk a little bit more on room placement and some different scenarios, but that's kind of the first step of contact precautions, is looking at what is appropriate for that situation. Using PPE appropriately, which in this instance would include gloves and gowns. And so wearing a gown and gloves for all interactions that may involve contact with a resident or the environment of a resident. And that would include donning donning PPE upon room entry and properly discarding before exiting the patient room is done to contain pathogens within that certain environment. This also includes limiting transport and movement of patients outside the room to medically necessary purposes. When transport or movement is necessary, covering or containing the infected area of, a resident, removing and disposing of contaminated PPE, and performing hand hygiene to transport patients or residents who are on contact precautions. And then donning clean PPE to handle a resident at the new transport location. Using disposable or dedicated patient care equipment like blood pressure cuffs. So if common use of equipment for multiple residents is unavoidable, then making sure to clean and disinfect such equipment before use on another patient. And then the last for contact precautions is prioritizing cleaning and disinfecting of the rooms of patients who are on contact precautions, ensuring that their rooms are frequently cleaned and disinfected at least daily or prior to the use of another patient if it's a situation where they're being transported out and someone else will be transported in, and then focusing on frequently touched surfaces in the room and the equipment that was used on that resident. Droplet precautions is next. Thank you, Rebecca. So again, this would be for a situation where there might be a resident who has pertussis, influenza, adenovirus, rhinovirus, some of the other like group A strep. So some of these situations they all would require droplet precautions. So that would be requiring to put a mask on the patient, if and when that's possible for source control, to avoid, continued exposure, ensuring appropriate patient placement in a single room if possible. Sometimes it's not possible, but there are some recommendations we would have if that is the case, and we'll talk about that here in a little bit. Using PPE appropriately, so donning a mask upon entry into the patient room or the patient space. Again, the environment's also important, especially since there's the possibility of droplets in the air and on the surfaces, and limiting transport and movement of patients outside the room to medically necessary purposes. If it's required that there is movement, again, it's just having the resident wear a mask if possible and following respiratory hygiene and cough etiquette that we talked about in the beginning. The last we'll talk about here a little more in depth is airborne precautions. So airborne precautions would be warranted with viruses such as measles, any sort of SARS, varicella, or chickenpox. Those would warrant airborne precautions. So again, this would also include putting a mask on the resident if and when possible, ensuring appropriate patient placement in an airborne infection isolation room, or they're called AIR with 2 I's, which is according to isolation precautions. When this can't be done, then placing the resident in a private room with the door closed can help reduce the likelihood of airborne transmission until they're able to be transferred. Really, in the terms of, long-term care is more so just having them be alone in a room to reduce the risk of other residents or other staff being exposed, and then restricting susceptible staff from entering the room. So if you have any susceptible staff who are susceptible to things like chickenpox or smallpox or have other immune conditions, then kind of limiting or restricting them from entering those rooms. Using PPE, which it would include a N95 or a higher level respirator for staff. Again, limiting and transporting the movement of those residents, and then providing immunization for those who are susceptible as possible following unprotected contact with a vaccine preventable infection like measles or varicella or smallpox. Okay. That was a lot of talking at you. I'll try to speed up so we can get to some of the fun resources we have. So next is the importance of PPE. Again, just some of the couple really key components of PPE that we wanted to highlight is that wearing proper PPE protects healthcare workers from pathogens through exposure prevention to fluids and respiratory droplets. And really, one of the things I think that is the biggest importance is because it's an effective strategy for both staff members and residents, especially important when there's no treatment option for illness. So something like human metapneumovirus, when there's no treatment option, then that's when infection prevention and proper PPE becomes, really the only option for increased exposures to others around the community. So that's when PPE and the importance of PPE becomes, most prominent in a community. And then another thing is just the importance of properly donning and doffing to avoid contamination. And then providing breathable types of PPE to keep your staff comfortable, as sometimes, if they're having really full PPE on all day, that can be a lot to take in. So, and then we'll move just briefly into the sequence of donning and doffing next. Okay, so the sequence of donning would be to perform hand hygiene, then put on a gown, mask, eyewear, and then gloves. And then doffing would be kind of the reverse, so taking off gloves, eye protection, which would be goggles or face shield, mask, gown, and then performing that hand hygiene. And we provided a couple of videos that staff can watch to go through that sequence. It's very easy to go through the motions and kind of forget about what the sequence is. So having that down will help avoid contamination and, again, help better protect the staff and others around those who are currently ill. Next slide, please. Okay, so as promised, just talking through some of the resident placement issues that we've worked with over the last couple of years. So, in instances where a resident does need to be placed into isolation, that can come with challenges. The first choice, the first preference is always having that resident move or be in a single room if they do have someone else in the room with them. The second instance, if you don't have any single rooms available, they aren't able to transport to another room, or they don't already live alone, would be to place them with others who have the same communicable disease. Now, within that, that really should have confirmatory testing to ensure that they are experiencing the same communicable disease, instead of just saying, well, they have similar symptoms, we think it's the same type of illness going on. You don't want to then expose both of those residents that maybe don't have that confirmatory testing to what the other resident has. So you'll want to make sure that they do have the same type of communicable disease, but that would be the next step, is moving in residents together that do have confirmatory testing for the same type of communicable disease. And that's a type of cohorting. If that's not possible, so there's no single room available, there's nobody else with the same type of communicable disease, then and they must share a room, then the next step would be to create a barrier with a curtain between residents. And then this kind of treats this allows staff to treat the rooms as two separate areas. And so if the resident is in droplet precautions, then you would want to increase the airflow, opening window if possible, with air quality and the snow and stuff. Sometimes it's not always possible, but if there are parts of the day that do allow for that, opening the window to allow for that airflow. And then installing a portable HEPA filter in the room, if that's another possibility, but not putting on a fan. We really want to try and treat these as separate areas and have the airflow be as much as possible with restricting exposure. And then donning and doffing between each resident. So walking into one side of the room using PPE just for that side, donning and doffing it in that side, and then treating the other part of the room as a separate room. And that's another way to, again, reduce exposures to staff and to the resident sharing a room. Okay, next slide, please. Okay.
Thank you.
Oh. If you're on the phone, I don't know if someone is off mute, but if you wouldn't mind muting. Okay. So how do we make these fun again? Again, they can be really dry, and I think a sense of burnout is really common, especially after we went through COVID and there was constantly guidance changing and a lot of precautions that were warranted all the time. And so one of the ways a couple of the ways we suggest is kind of switching up the type of education you're providing, little refresher courses. So This can include scenario-based roundtables where you maybe say, okay, let's place staff at different tables. We're going to walk through a situation where a resident has this type of virus, and then you have them walk through the sequence of what precautions might be warranted, the series of donning and doffing, something like that, where you could kind of challenge them to different scenarios that are, realistic scenarios. Performing fun hand hygiene challenges. So there's, black lights, which can be a little bit more expensive. So if you don't have black lights in your facility, there's a glow in the dark gel that can be purchased on Amazon. That's a more financially savvy option that you can use, and that allows then for staff or anybody who's washing their hands and wanting to do this challenge to see areas that they might have missed during hand hygiene. So that's just a fun way, and I suppose a humbling way to perform a hand hygiene challenge. Using unit competitions with PPE donning and doffing, hand hygiene compliance with secret shoppers, offering prizes for units or a rotating trophy, something like that. It's just a fun way to ensure that PPE is, being accurately done and doffed, and just warrant in different situations where it's warranted, it's properly educated, or they're properly educated on which type of precautions they should be using. Okay, next slide, please. So just a couple of PPE mishaps we wanted to mention. Using gowns more than one time when they're not reusable gowns. So again, this can even be from a situation where you have two residents in one room and you're treating them as two separate rooms. Using that gown from one side to the other would be, an improper use of that gown. Removing PPE inside the room instead of outside of the room. Again, we want to keep all the contaminants and the germs in that one area. And so if you're removing your PPE inside the room, then you're not properly doffing your PPE and providing yourself maybe an increased risk to exposure. Forgetting to change gloves and perform hand hygiene when moving from a dirty task to a clean task. Forgetting to perform a seal check on an N95. So important to have staff who are wearing those N95 respirators fit tested and performing seal checks when they're wearing their N95s, again, to protect themselves from the risk of exposure. And then forgetting to clean reusable equipment, even when the resident is not on isolation, because it's important to clean that reusable equipment from any time it's used on a resident and move to another resident. All right. I know we're almost here and we're moving through time. We're cruising. So we can pull this up for a second, but I don't think we'll have time to play. But we did create a Jeopardy game. And so you can do any amount of teams you want. And then Rebecca, if you want to hit start. Basically, we went through kind of what we talked about today and provided some fun Jeopardy questions. So let's see, Rebecca, if you want to just click one of them. So this item is used when your hands may touch someone else's body fluids, certain hazardous drugs, or some potentially contaminated items. And then Rebecca, if you hit the space bar, it'll show that they're perfect. So gloves. So there's different types of scenarios here that you could walk through with your staff. So I think Stacy just put that link into the chat, but we'll send this out as well. But this is just another way that you can help bring that education into your staff. Okay. And then I'm actually going to pass it over to Stacy for the second half of this. She's going to talk about human metapneumovirus and then conclude our presentation. So thank you very much. Over to you, Stacy.
Hi, everyone. Good to have you on today. I just wanted to talk a little bit about human metapneumovirus, big word there, but HMPV. So this is a fairly newly discovered virus. Only really had been recognized since about 2000. And basically, it's very closely related to RSV. And it's really not something that we ever tested for before. But now that laboratories are doing respiratory panels, like on the BioFire, that type of thing, where they're testing for multiple viruses, we're seeing more and more of it. so the most of the time we just considered it a nasty cold, a respiratory infection that they couldn't identify. And that's why we're seeing it so often now. So it is cold-like symptoms. Fever is very common. Unfortunately, hypoxia is another symptom of this. And then viral pneumonia. It strikes small children and the elderly the most. For the rest of us who have healthy immune systems, it is just a really nasty cold. So incubation is 1 to 10 days. And people are sick for about a week, 7 days after they get symptoms. So they get it from, just like any other cold, from sneezing and coughing or touching a surface that had just been contaminated by sneezing or droplets. So CDC does recommend contact precautions with these individuals, just like RSV, but you would want to wear a mask and eye protection while you're taking care of that patient. So because it's a virus, there is no treatment. There's no antivirals for this. It is only supportive care. And we recommend that you do pulse oximeters with your vitals to identify early hypoxia. Unfortunately, there have been some large outbreaks in Boulder County of HMPV. It has resulted in individuals being hospitalized as well for viral pneumonia. And out of those outbreaks, anywhere from 6 to 7 people in each facility had been hospitalized. So it's something to just put on your radar. It's like, gosh, there's one more thing to worry about. But now that we have the ability to identify it on respiratory panels, I think we're going to see more and more of it. Um, both of these outbreaks, last, several weeks. We've seen it in both staff and in residents. So, and certainly if you have any questions about it or you're seeing this in your facility, please let us know. Next slide. The other thing I just wanted to let you know is that some of our team is leaving, and that includes Katie, who just gave you your presentation. Her last day is June 16th. I believe. So the only people that will be, and Rebecca Herman is also leaving, and she is gone on the 1st. The reason we're having all these departures is that a grant that funds a lot of our staff is ending at the end of July. So, and we appreciate everything they've done for this team. Katie has been here since the beginning of COVID, and everyone will be missed sorely. So you still have to put up with me. I will still be available, and that is my email there. Debbie Martinez will also be here till the end of July, and so will Sarah DeLong. But if you have any questions or any concerns, please reach out to me first, and or use our EPI mailbox, and that will make sure that if I'm gone, that somebody else will get that email. And that is our main number or contact number. And I believe that most of you have my my phone number for my office as well. So, and I think that's it. Next slide. All right. I know we're a little over time, but I'm just going to open it up and see if anybody has any questions. All right, I'm not hearing any. I'm glad that you guys jumped on today. I hope this was helpful. Our next call will be, what did that say? June 26th, I believe. And we will use one of the topics that you guys requested. And until then, you guys have a great June and enjoy the rest of your day. Thanks, guys.